I'm Lauren Henke, and here with my co host, Stephen Chun, for another episode of the NRG Oncology podcast. Today, we are joined by Dr. Deborah Bruner, who is on the NRG Oncology Executive Committee and has played major roles as the principal investigator of the National Clinical Oncology Research Program, or NCORP, and was principal investigator of the Legacy RTOG Cancer Community Oncology Program, CCOP. Dr. Bruner has received millions of dollars of federal grant funding in support of her research. At Emory University, Dr. Bruner is the Senior Vice President for Research for the university and is the Robert W. Woodruff Professor of Nursing and Professor of Radiation Oncology.
I have to confess that I have seen Dr. Bruner's name on so many publications and newsletters that at one point I thought she was a physician scientist, but in fact, she is a nurse by training who went on to pursue a PhD from the University of Pennsylvania. Dr. Bruner, your career is truly unique. Could you just start off by giving us an overview of your journey and how you started down the clinical research path? And especially for the non physician investigators out there, when and how did you realize that the sky was the limit with NRG Oncology?
Well, Dr. Chun and Dr. Henke, thank you so much for having me. I love these podcasts. I've been enjoying them, and it's fun to join you both. Yes, before I had a PhD, I was a clinical nurse. I was a clinical nurse specialist in GYN oncology and then radiation oncology. And it was my mentor, Dr. Gerald Hanks at Fox Chase Cancer Center, who himself was world renowned in the patterns of care study that changed practice for radiation therapy and actually laid the way for quality assurance across many disciplines. He was the one that introduced me to RTOG and clinical trials, saw something in me, probably I didn't see myself, and encouraged me to get involved. I joined RTOG in the late 80s, and in 1989, the NCI put out a call to the cooperative groups asking for them to start to include quality of life in their endpoints. It's hard to believe that even up to almost 1990, that was not routine in clinical trials. So everything we measured was mortality and morbidity. It was physician-related or reported toxicities, but we did not include the voice of the patient. We were finding that there are many studies that showed that for things that we can't scan or do a lab test for, things like pain, things like sexual function, that physicians and nurse practitioners were about as good as flipping a coin in actually describing the patient's subjective experiences after cancer. It became clear to the NCI that including patient-reported outcomes was actually a critical endpoint in cancer clinical trials. So I do have a funny story though. I wrote the first quality of life study as a companion to a bladder cancer trial in RTOG. And I still did not have my PhD. I was a master's prepared clinical nurse specialist. And I sent the study in to the NCI. And there was a nurse at the NCI who called me. Her name was Mary McCabe. I will never forget this. And she said, Deb, this is not very good, but we really want the cooperative groups to start measuring quality of life. So we're going to let you do this, but you have to do better in the future. And so I applied to the University of Pennsylvania and obtained my PhD.
Given how much of a leader and innovator you've been, I can't imagine this could have all been easy or handed to you on a silver platter. When you started down this path, there probably weren't many nurses or women to look to out there as role models in this type of cancer research. Yet you have arguably had one of the most productive and prolific careers in the history of the NCI-sponsored cooperative groups. Could you speak to some of the adversities that you've encountered and how you've navigated them throughout your career?
I have to say that I was frequently the only woman in many committees. I was the only female investigator on the transition committee from RTOG to NRG. But not only am I the only woman frequently, I was the only nurse, most certainly. I am the first nurse to ever be principal investigator of one of the national cancer cooperative groups, either for CCOP or NCORP. So no, I didn't have nursing role models, and it's in some ways freeing and fun to be the first. You can create your own path, nor did I have anyone to, I guess, live up to at that time. So maybe the bar was low. On the other hand, navigating, especially in the 80s and 90s, when the cooperative groups were very male MD dominated, which has changed dramatically since then, but at the time it was male MD dominated, was certainly not always easy. I don't think the stories are much different from corporate female leadership, and I wish it was different for women MDs or nurses today. I think it has improved, but I don't think all of those hurdles have been crossed. I was of the generation where your mother took you aside and told you how the world was, explained what to ignore, what to challenge, and that you needed to be or to have a thick skin, in quotes. And I realize now that that thick skin meant ignoring a lot of bad behavior, and it meant persistence, and it meant hard work. I hope that the bar is evening out, because I don't believe that women or nurse investigators should have to have a different bar. As long as your work is good, your concept and research is rigorous, we should be equally accepting. I hope we're moving towards that. I can't say we've achieved it yet.
I think that that is still something that rings really true. I think I've had similar conversations with my mother and female colleagues, and I like what you say about how it has in some ways taught you persistence and hard work in a unique way. I think sometimes those same expectations about my behavior or the way that we navigate through life, those differences have honed me to made me sharper maybe and a bit more of who I am. But I agree that some of those things, although they're improved, certainly still exist. It's remarkable the way that you've moved through those obstacles.
I could also say that I've had champions. Certainly my mentor, Dr. Gerald Hanks, was one. Dr. Wally Curran, I worked with him at Fox Chase in his first job as a radiation oncologist. We have become great colleagues, very respectful of each other's work and abilities. And he also gave me great opportunities, as Dr. Hanks did. I wish I could say that I had female mentorship in the cooperatives, but again, at that time, I was sort of singular in some of the work that we were doing.
I'm just amazed at the amount of trailblazing you've done in the NCORP space and as a role model to many of our young investigators, both men and women. And I wanted to circle back to a topic we talked about earlier in the podcast. Dr. Bruner, your career with NRG Oncology has been synonymous with the National Clinical Oncology Research Program, or NCORP. We've done some podcasts on NCORP trials before, but haven't had a chance to have an in-depth conversation about NCORP. Could you go through how NCORP started and how NCORP's accomplishments changed the face of NRG oncology over the years?
I can't remember the year it started. It's been around for quite some time, certainly not as long as the NCI or the clinical trials NCTN. But several decades ago, the NCI realized, quite appropriately, that most cancer care, even today, is given in the community. Hugely important then to reach the community with our clinical trials. They started mostly in academic centers, and it was critical that we bring these to communities, including rural communities, where clinical trials were sorely needed. So the NCORP started with this focus and has continued to this day to focus on the community. Right now, the NCORPs have 7 research bases. Research bases are the component that creates the intellectual property, the protocol, and handles the infrastructure. And then there are 46 national community centers, but they have thousands of affiliates. So we are reaching thousands of patients in the community, which is critical. In fact, over 20,000 patients to the NCI cancer treatment trials, or 20% are coming from rural America now through the NCORP programs. Over 42,000 patients to the NCI cancer prevention trials are coming from rural America. And over 100,000 people have been screened in our NCORP trials. So it's really reaching key demographics that before this were not available to them. And that's been a wonderful part of this. The other thing that is now coming to light is that advanced practice providers, mostly nurses, give more cancer care in rural communities than do MDs. It has only been recently that these statistics have been well circulated. We must now do better in reaching advanced practice providers and getting them involved in cooperative group trials so that they can accrue patients, particularly in the rural settings, to treatment trials. But also, the NCI has changed their guidelines, and now advanced practice provider nurses can be the principal investigator on NCORP concepts. So who better than nurses who manage much of our symptom management and prevention to bring forward concepts for symptom management and good prevention? The NCORPs also now do cancer care delivery along with symptom management and prevention. We do screening, and we also are the arm of the NCTN that focuses on quality of life, patient-reported outcomes, and cancer care delivery, which is mostly implementation science. When we find things that are guidelines worthy, we then work to try to implement those guidelines into clinical practice. So all of that is covered under NCORP, and it's both really focused on community feasibility, and now welcoming advanced practice providers. In fact, for advanced practice providers, at the July 2025 meeting, NRG has held the first committee meeting of advanced practice providers. We will be putting out more information in our newsletters. We are seeking advanced practice providers to join NRG Oncology, and more information is on the NRG website.
And I'm so grateful for the opportunity that I had to participate alongside my advanced practice provider, Molly Tate, at the July 2025 NRG Oncology meeting. I just think it's such a great forum to encourage our entire multidisciplinary team to get involved with NRG Oncology trials.
Couldn't agree more. And, Dr. Bruner, one of the things you mentioned about the reach of NCORP, particularly for rural cancer patients, I think is just such an important aspect, obviously a central aspect of NCORP, but for those who are less familiar, it's just so critical the way that NCORP helps us to reach that set of patients to give them access to clinical trials. And at a time of considerable uncertainty over federal funding and priorities, we don't want to take anything for granted at NRG Oncology. There's been a lot of chatter lately about cutting federal support for the National Cancer Institute, and NCORP specifically has come up as a possible target for cuts, which I think is particularly sad in consideration of, I think sometimes people find a bit of fault with academic medicine as being accessible to those in cities and in large academic settings. And they don't think of this as a cut perhaps for these rural patients. How concerned are you about the future of NCORP? And can you make the argument, perhaps to the American taxpayer, for the importance of NCORP and patient-reported outcomes in cancer research?
I am exceedingly concerned about the future of clinical trials and cancer care in the United States, given the changes we're seeing in the NCI. I can most certainly make a good argument for the public support of cancer clinical trials. People need to realize that every drug that they're on has been tested in a clinical trial. So these clinical trials are critical in testing best practices against new practices to treat all the things that we're talking about in cancer. But in addition to that, the reach to the community is what I'm most proud of the NCORP program, and that we are reaching these tremendously underserved populations through these community programs. In NRG Oncology, almost 1/3 of the patients on treatment trials are from our community NCORP sites. Critical to making sure that what we're testing is available to everyone. The other thing that we pay a great deal of attention to are the populations that do enroll on our trials. We want to be sure that these treatments are equally effective in women, equally effective in race and ethnicity, because we have seen drugs that differ in outcome by gender, by race, by ethnicity. And so these clinical trials are absolutely critical in making sure that everyone gets the benefit of these interventions. We need to do more to directly speak to the community, to put our findings and our work in a more public format that can be understood by all. At Emory, I actually have a 2-year program on public scholarship for investigators so that they can share their impact with the community. And I don't think we've done that enough. And it's something we need to do more of.
On this note, can you directly speak to patients, caregivers, and survivors out there what the tangible benefits they have seen from NCORP that they might not have been aware of? How do you believe that the ongoing work of NCORP will directly translate into a concrete outcome to better cancer treatments for patients?
We have many clinical practice changing studies. And what that means for patients is that the findings of our research have changed the way doctors treat cancer patients in a very positive way. And I can give you some very brief examples. We are the first cooperative group to show improvements in cognitive function after brain radiation therapy, with multiple trials that have looked at drugs that were previously used in other settings for dementia, like a drug called memantine. We've done very novel radiation therapy work in hippocampal sparing. And in fact, I had just recently listened to one of your podcasts from May, where you interviewed Dr. Vinay Gandhi, who has led so many of these studies in hippocampal sparing, which means that we try to give radiation to the tumor site and areas where even we can't see the cells, but fear they may go in the brain. But the more radiation we give to the brain, the more possibility of memory loss and executive function loss. So these hippocampal sparing trials are really novel in trying to spare an area in the brain called the hippocampus where memory lives. Patient-reported outcomes are definitely changing the lives of patients. They're most important in settings where you're testing two treatments, and if they are very similar in the outcome, meaning if the treatment on arm A and arm B are very similar in survival, or very similar in disease-free survival, or similar in toxicities. How do we make a choice? How do we know if we should pick the standard therapy or the new therapy, especially when one may be more expensive than the other? Well, that's what the NCORPs add to treatment trials. We look at those secondary endpoints of patient-reported outcomes, quality of life, and cost effectiveness to give the patient, when they're making a decision, a rich evidence-based data to make their decision of whether they want these treatments and how they would affect their daily living. We have, for example, a series of studies in hypofractionated radiation therapy for prostate cancer. And in fact, we've recently changed clinical practice guidelines for hypofractionated low risk prostate cancer, 0415, that was the study number. And the lead on that was Dr. Robert Lee. But because the outcomes were similar on regular fractionation, which is a longer schedule for patients, meaning they have to come in more days, more weeks, to a lower hypofractionated schedule, which means much more convenience for the patient. But what was important is there was also no change in quality of life, which means that you could come in less days for less radiation and get the exact same survival, toxicity profile, and quality of life. And so that makes it fairly easy for patients to pick a hypofractionated regimen. These have been included in the NCCN guidelines, the PDQ guidelines, and other guidelines just from this one study.
At the beginning of this podcast, we touched on your previous role as Assistant Dean for Faculty Mentoring at Emory. And we know you continue to mentor faculty as Senior Vice President for Research. The world has changed a lot since you paved the way for patient-reported outcomes research and non-physician investigators at NRG Oncology. What are the biggest challenges your mentees are seeing today in establishing their careers? And for nurses, PhDs, or other non-physician investigators out there who are passionate about cancer research, what kind of advice can you give specifically to them for getting involved and being successful with NRG Oncology?
Well, the current challenge in the support for research, whether it's R01s or NCI clinical trials, is of concern and does cause anxiety. We try very hard to talk about how we can pivot our research to be sure that it is aligned with federal priorities. If you choose to take federal funding, you must be aligned with federal priorities. And there are absolutely ways to do that. And I think that mentorship is absolutely key. The NCORP offers a great deal of mentorship. So how do you get involved? Well, first of all, you need to show up. Read about NRG, take a look at some of our clinical trials. Our NCORP trials, we have 9 open trials right now with a vast variety of topics. We've got a 9,000 patient screening trial looking at 5 versus 10-year colonoscopy and seeing if they are equivalent and can we decrease healthcare costs and increase convenience for patients and providers by going to 10 years. On your podcast, you had talked to Dr. Ed Tanner about our study of sentinel node biopsy for uterine cancer. We've got studies looking at stereotactic versus hippocampal whole brain radiation therapy for brain mets in small cell cancer. That's another podcast you did in May, which was excellent with Dr. Gandhi. We've got trials that are building on our work in mitigating cognitive outcomes after radiation therapy by now testing cognitive training for patients that have been cognitively impaired after breast cancer. And we've got studies that look at managing symptoms with oral anti-cancer drugs. We have trials looking at a protective agent for head and neck cancer patient for all of the oral symptoms and esophagitis that patients face. We have a study for high-risk asymptomatic bone mets building on some work that we did in bone metastasis showing that 8 gray in a single fraction is equivalent to the pain outcome for 30 grays and 10 fractions, which is also much more convenient and cost effective for patients. And then we have another study just opening on harnessing e-mindfulness. So you can see the variation is quite wide, which means that young investigators and advanced practice providers across the spectrum, from medical oncology to radiation oncology to surgical oncology, are very welcome in the NRG. And it's not seniority that gets you onto a trial. It's really showing up, being involved, using your voice, and coming up with good concepts, because it's not just senior members that get to put in a concept. We really judge concepts on their merits. They definitely need preliminary work. And so we are looking for that preliminary data. But so getting involved, showing up at NRG meetings, we meet twice a year in person. There's a new investigators committee that is for all new investigators, MDs and PhDs. People are most welcome to show up there. And as I mentioned, we are desperately seeking advanced practice providers to be involved in both putting patients on cancer clinical treatment trials and for developing concepts for those NCORP trials that I just mentioned.
Well, Dr. Bruner, I want to thank you again for joining us on the NRG Oncology podcast and for the decades of leadership and trailblazing you provided us.
It's truly been my honor and joy to be involved in this, and it is incredibly rewarding if we can think that we've helped a single cancer patient somewhere along their trajectory, either in survival or living with the outcomes of survival in terms of quality of life. So thank you for having me.
Today, we've heard from Dr. Deborah Bruner, the principal investigator of the NRG Oncology NCORP program, speaking about her long career in patient-reported outcomes and community-based research. The NRG Oncology Group is supported by funding from the National Cancer Institute, and content of this podcast does not necessarily reflect the official views of the National Institutes of Health. Thanks, everyone, for tuning in, and happy clinical trials.